Hello, everybody. I am David Gudis from Columbia University, and I will be speaking about cystic fibrosis chronic rhinosinusitis, or CF-CRS. And CF-CRS is a very interesting disorder, I think, and an enormous opportunity for rhinologists because it gives us a chance to help patients not just with their sinonasal quality of life, but oftentimes with their overall systemic health and well-being as well. I have nothing to disclose. I will be going over a definition of cystic fibrosis, the burden that sinus disease has for patients with cystic fibrosis, the anatomy and physiology that makes CF sinuses unique, how we can evaluate the sinuses, the relationship to pulmonary disease, the evidence for treatment, and what the future of CF-CRS might hold. So what is cystic fibrosis? Well, CF is an autosomal recessive disorder which results from a mutation of the CFTR gene on chromosome 7. And the CFTR gene, or the transmembrane conductance regulator protein that it codes for, has a job, and that job is to transport chloride across the cell surface. When there's not enough chloride being transported because of this mutation, especially if it's homozygous, then there's not enough sodium chloride on the cell surface. And if there's not enough sodium chloride or there's not enough salt, then there's not enough water. And when there's not enough water in the mucus, then the mucus is too thick. And when the mucus is too thick, patients have all of the pathology that results from cystic fibrosis. Now, these mutations have been discovered across every stage of this protein's life cycle, from production to its degradation and turnover. Thousands of mutations have been identified at every stage of this process. So why has this mutation persisted? Well, it turns out that being heterozygous for some mutations is probably helpful for human survival evolutionarily. And the prototypical example of this is sickle cell disease. When patients are heterozygous for a sickle cell mutation, it is thought that there is a protective element against malaria. Well, it turns out that being heterozygous for the main cystic fibrosis mutation in the Western world, delta F508, is probably protective against diarrheal illness. And delta F508 is by far the most common mutation for cystic fibrosis in Canada, the US, Brazil, Western Europe. And that's probably why this mutation has persisted in our gene pool. We know that patients with cystic fibrosis have a reduced life expectancy and a reduced quality of life. And I love this chart, which shows how the life expectancy of CF patients has changed relative to different interventions that we've developed along the way. With anti-staph and anti-pseudomonal antibodies, we see an enormous leap in life expectancy. With lung transplants, we see yet another leap in life expectancy for patients with cystic fibrosis. And I believe that now in 2022, we are on the cusp of another enormous leap in life expectancy for cystic fibrosis patients, hopefully to normalize it because of new CFTR modulator therapy, which I will get to at the end of this lecture. So what does this mean for patients? Well, the Cystic Fibrosis Foundation in 2012 did a survey of their membership. And this is not a scientific study, but when you add together the sinus disease and the polyps, these patients were reporting a higher percentage of sinus disease as a problem related to CF than any other problem CF patients have. And this is interesting. We know that the head and neck manifestation of CF, by far sinus disease is the most common. When we look at patients' CT scans, over 90% of patients with CF will have some element of sinus disease. If we look at the EPOS criteria or the ICAR criteria, where we require a combination of subjective and objective metrics, then the prevalence drops to about 85%. If you directly question patients about their CF disease, their sinus disease, only 50% of CF patients will report that they're symptomatic. And if you don't directly question patients, then only 10 or 20% might complain of sinus symptoms. Why is that? Well, maybe we don't know exactly what CF-CRS is. We know that chronic sinusitis has a significant impact on patients' quality of life, as measured by utility scores. But for some reason, CF-CRS appears to be less symptomatic than other forms of chronic sinusitis. So we don't know. Is it possible that CF-CRS is an asymptomatic disease? A lot of people like to say that CF patients may have adapted to this because they've had it their whole lives. And I always have trouble with this explanation because we all know patients who have had sinus disease for decades and decades, and it certainly still seems to bother them. I don't know why CF would be different in this regard. Others have postulated that CRS symptoms might be overshadowed by other medical problems, that when patients are worried about a lung transplant, maybe their sinus problems are just less problematic. And this explanation has never quite made sense to me either, because we know that other comorbidities don't seem to minimize sinus disease. In fact, other medical comorbidities might even make your sinus symptoms seem worse. So I don't think we exactly understand why patients with CF-CRS seem to have relatively lower degree of symptomatology than other patients with chronic sinusitis. And when we look at all these consensus statements that have been developed to define chronic sinusitis, one specific symptom I find interesting in the CF population, and that's decreased sense of smell or hyposmia. We know that patients with CF have a reduced sense of smell relative to normal patients. This has been studied in a few different clinical trials, and the results are consistent that their olfaction is impaired, oftentimes independent of a reported history of sinus disease. And why is this so important? Well, CF patients have a decreased quality of life at baseline. They have a risk of malnourishment at baseline, and patients with olfactory disorders have a decreased quality of life and risk of malnourishment. So this can compound and be very troublesome for CF patients. Now, CF sinuses are unique. I can show this CAT scan to a rhinologist, and they will know right away that this is a patient who has cystic fibrosis. And why is that? Well, we can see sinuses are hypoplastic. There's oftentimes demineralization from a lot of pus under pressure. Sometimes in kids, this will cause the medial maxillary wall to bulge all the way to the nasal septum, causing nasal obstruction. And CF patients often get these submucosal abscesses. And these are not true mucoceles, although they might have that appearance on CAT scans, because it's not a contained mucoperiosteal cavity. It's basically a pocket of pus that for some reason the epithelium seems to grow over. Here's an example of a young woman who had comprehensive sinus surgery for sinus disease, but we can see in the bottom of her maxillary sinus, she's starting to scallop out a little hole in her alveolus there. When we open that up with a maxillary antrostomy and turn it into a megaantrostomy or a medial maxillectomy, we can see this little mucopyocele or submucosal abscess or whatever you want to call it burrowing into the floor of the right alveolus. And here you can sort of see on her contralateral side the way that the epithelium starts to grow over these little pockets of pus. And I'll show a few more examples of that. This is a young woman, lung transplant patient who had chronic facial pressure. This is what her CAT scan looked like before medical therapy. And after 1 month of IV antibiotics, her sinuses still look like this. So what are we going to do about this patient? She has a wide open maxillary antrostomy. Now, sinuses have a natural mucociliary clearance pathway. And in the maxillary sinus, that mucociliary clearance carries stuff against gravity up and out the infundibulum into the nasal cavity. Now, this mucociliary clearance is so powerful that even something like a dental implant can get lifted up off the floor of the sinus as the cilia try to propel it out of the natural os of the maxillary sinus. So what can we do for patients who have refractory chronic maxillary disease? Well, here's where we can start thinking about a medial maxillectomy. And there's plenty of evidence to support this surgical intervention for a number of different sinus inflammatory and neoplastic disorders. Here we're on the right side of the nose. I'm clamping the inferior turbinate with a hemostat, just like some people do for a frenulum, elevating an inferior meatus mucosal flap off of the medial maxillary wall. And once we have that mucosa up and we have this medial maxillary wall exposed, we can start to drill, and we can bring this all the way down to the floor of the nasal cavity, get rid of all the mucosa in the lumen, use that little mucosal flap to line the sinuses, and then about a month later, we can see medial maxillary cavity is wide open. Now, we haven't cured cystic fibrosis, of course. We'll still see some thick mucus and pus and stuff like that. But here our suctions can get in here better, our irrigations can get in here better, and it turns out to be a very effective treatment for cystic fibrosis, chronic sinusitis. And radiographically, you can see how powerful this intervention is for these patients in reducing the inflammatory and infectious burden. Now, some of these mucosal abscesses, submucosal abscesses, can burrow into the posterior table of the frontal sinus, sometimes into the orbit, and keeping the frontal sinus open in these situations can be very challenging. Here we can see we've got a wide open sphenoid ethmoidectomy. And as we start to get up into this frontal sinus, I've tried every formulation of stents and spacers to try to keep these cavities open. But it can be sort of a challenge. Here you can see the orbit is dehiscent from this abscess. And in a case like this, sometimes I like to try these silastic stents to keep this cavity open as it epithelializes. but it can be very difficult to maintain long-term patency for a narrow frontal in a cystic fibrosis patient. Sometimes these cavities, these abscesses can erode into the medial orbit, and these can be a little challenging because sometimes the pus under the mucosa can look exactly like periorbita under the mucosa. So here we're going to look inside the nose. We can see there's a little bit of this whitish, yellowish discoloration along the medial orbital wall where the bone is dehiscent. And turns out sometimes just palpating and feeling with some of our instruments can demonstrate which of these cavities is pus and which of these represents orbital fat or something like that. Now, every form of chronic sinusitis has some constellation of mucociliary clearance dysfunction, inflammation, and infection. We know for CF, the pathophysiology begins with impaired mucociliary clearance. These patients have very thick mucus, and there seems to be a dose-dependent response such that even being heterozygous with a CFTR mutation increases the risk of CRS. So these are patients who don't have CF, but if you look at a bunch of adults with CRS, there's an increased incidence of a CFTR mutation being heterozygous. Same has been demonstrated in the pediatric population. So what happens when the mucus is too thick? Well, it's a great place for bacteria to grow. Early in childhood, it's the typical staph, strep, and moraxella, but CF patients develop these gram-negative organisms that are very, very dangerous. The age of onset of Pseudomonas in the lungs is even associated with life expectancy, and that's how virulent and dangerous these bacteria are. Pseudomonas is a gram-negative rod, a facultative anaerobe, and it's great at making biofilms, which makes it very difficult to eradicate. Mutations have been identified in the sinuses for all kinds of Pseudomonas forms that increase the development of biofilms, antibiotic resistance, and oftentimes these mutations are identified in the sinuses before they are in the lungs. So what happens with all this infection? Well, it turns into a massive inflammatory response. And rather than going into the nuances of the whole inflammatory cascade, one thing I think is very interesting about these sinuses, which is that we know any pocket of pus in the sinuses reduces the luminal oxygen tension. This has been demonstrated in purulent infections elsewhere in the body as well. We also know that Pseudomonas biofilms consume oxygen. Kasper Anais in Denmark has also demonstrated that the mucosal oxygen tension in these patients with cystic fibrosis sinus disease is reduced. And we also happen to know that hypoxia reduces not only CFTR expression, but also chloride transport with a normal functional CFTR protein. So this results in a massive inflammatory cascade where you have Pseudomonas biofilms consuming oxygen, reducing CFTR expression, reducing chloride transport in an already compromised environment. And it turns out to be a very difficult infection to eradicate, although it can be done. Now, a lot of times this inflammation will result in polyp growth. There seems to be an age-dependent association of polyp growth, but I feel like the polyp presence in these patients is sort of irrelevant to the management because in cystic fibrosis patients, the polyps tend to be neutrophilic. They are not eosinophilic like we often see in our atopic and asthmatic patients. So their steroid responsiveness is less. The neutrophilic infiltrate is greater. And the presence of polyps doesn't really change our understanding or management of patients with CF/CRS. Plenty of other inflammatory things happen in these patients that I won't get into, but this results in essentially a bacterial reservoir in the sinuses, and this has major implications for lung disease. We know that the genetic identity is preserved between the sinuses and the lungs in patients with CF/CRS, but the sinuses have a greater diversity of organisms, and many of these mutations I mentioned seem to present in the sinuses before they are in the lungs. So this represents a great opportunity for us to target these patients and try to make their sinuses better. So how can we evaluate the sinuses in these patients? Well, turns out using all of our EPOS or American Academy guidelines or ICAR guidelines, probably not great because these patients don't have a lot of symptoms. The presence of polyps, like I said, is not very helpful in these patients. What about imaging? Well, there's not a lot of data to correlate imaging in CF disease with outcomes or symptomatology, but it turns out that Lund-Mackay scores are not very useful in predicting sinus outcomes in CF patients. Turns out Lund-Mackay scores also don't really correlate, even to change as a result of surgical intervention or days in the hospital after surgery or need for IV antibiotics. So the imaging characteristics are probably not correlated very well to symptoms or intraoperative findings. How about quality of life? Well, symptomatology appears to be very different in these patients. It turns out that quality of life, SNOT scores, and FEV1, or forced expiratory volume in these patients, appears not to have a very good correlation, certainly once you're over 12 years old. So this is probably not a good way to measure CF/CRS either. How about PFTs or the presence of anti-pseudomonal antibodies, maybe the transplant status? All of these things might be useful in evaluating CF/CRS, but we don't have great ways to objectively measure this disease. One important consideration, of course, is whether or not the sinuses are infecting the lungs. Now, when we look in somebody's nose and see all this pus pouring down the back of their throat, it stands to reason that the sinuses could be infecting the lungs. But how do we prove that? Well, there was a study done in thorax looking at patients who underwent lung transplant, looking at patients who underwent airway cultures for Pseudomonas in patients with cystic fibrosis. And it turns out that Pseudomonas being present in the upper airways dramatically increases the risk of Pseudomonas being present in the lower airways, and the genetic identity is preserved, meaning these are essentially the same colony of organisms rather than a completely separate and distinct infection. Now, lung transplants turn out to be a great way to study this question because you're starting off with a clean slate on one end of the spectrum. There was a study done looking at lung transplant patients in 1997 who had cystic fibrosis, and they were compared to patients who did not have cystic fibrosis. And what this study showed was that all patients underwent the same postoperative management, but in patients who had cystic fibrosis, the Pseudomonas was identified in the lungs at a median of 15 days after transplant. So a lot of these patients aren't even out of the hospital yet, and Pseudomonas has now presented in their lungs. Patients without cystic fibrosis, for example, those with pulmonary fibrosis, they were 6 months post-op before they had the same Pseudomonas in their lungs. Now, other data has demonstrated that this genetic identity is preserved in these lung transplant patients, which really strongly suggests that the Pseudomonas from the sinuses is colonizing and infecting these brand new lungs 2 weeks post-op. Now, how is this getting down there? Well, it's possible that patients are breathing in these microbes or secretions that contain some of these microbes. It's also possible that these patients are developing tracheal colonization, and since the mucociliary clearance in the trachea is compromised similarly to that in the nose and sinuses, that the trachea is unable to propel the Pseudomonas out of the trachea, and instead the gravity ends up pulling it down into the lungs. Now, all of us swallow our mucus throughout the day, and we know the acidic environment of the stomach kills much of what it contains. But CF patients have an increased incidence of GERD or reflux disease, and I do wonder if some of these patients could be refluxing or aspirating what they have already swallowed before the acidic environment of the stomach has had a chance to kill some of these organisms. Lastly, cystic fibrosis patients have been shown to have a decreased sensitivity to cough. So I wonder if these patients are getting the same stuff in their lungs as everybody else, but they just don't notice it and cough as effectively as other patients. So how else can we demonstrate that the lungs and sinuses correlate in these patients? Well, we did a study here at Columbia where we demonstrated that when patients were treated for a pulmonary exacerbation of cystic fibrosis, they happened to also have a worse sinonasal quality of life at that time. Their SNOT-22 score was worse at the time of their pulmonary infectious exacerbation. And we demonstrated that this was not just patients with a worse baseline sinus disease, because at their regular routine visits, their sinonasal symptoms were back at a baseline level. Dr. Rodney Schlosser and I have a whole textbook looking at the unified airway in case anyone's interested in some of these associations for other similar diseases. Now, how do we treat these patients? Well, before we treat these patients, we have to understand what our goals of therapy are. And when I'm seeing a patient with CF/CRS, I think about 3 goals. Number 1, I want those patients to feel better. Number 2, I want to reduce or potentially even eradicate the bacterial burden in their sinuses. And number 3, if I'm lucky, their lungs might get better too. For the medical management of cystic fibrosis, up until the last couple of years, there was very little in the literature. A couple studies looking at topical medication, and a couple studies looking at topical antibiotics and topical steroids. These medication trials have demonstrated that there's probably some mild degree of symptom improvement, but it does not appear to be significant for most patients. Now, one study in the Journal of Cystic Fibrosis from 2014 demonstrated that topical Dornase alpha, or Pulmozyme, actually seemed to improve symptoms in addition to improving pulmonary function. And that's unique. It's very difficult to demonstrate improved pulmonary function after a rhinologic intervention, but this clinical trial did so. There was, a second trial that similarly demonstrated that Dornase alpha seems to improve symptoms in addition to pulmonary function. Inhaled tobramycin also seems to improve symptoms, but probably not pulmonary function. There was one study that came out in 2019 looking at ivacaftor, which was the first CFTR modulator to hit the market, and I'll speak a little bit more about those shortly, which demonstrated some improvement in sinonasal symptoms, but not across the board. Other medical management has been extrapolated from other chronic rhinosinusitis forms, including nasal saline or using topical steroid irrigations, topical antibiotic irrigations, even alternative treatments like baby shampoo, macrolide therapy. In general, medical management seems to improve symptoms somewhat. How about surgery? Well, what are the goals of surgery? Number one, we want to reduce the inflammatory and infectious burden. Number two, we want to improve topical medication access. And number three, I think it's really important that we have an anatomical cavity that facilitates office debridements, because bringing these patients back to the operating room might not be an option as their pulmonary function declines. Now, surgical management has been studied extensively in these patients. There's one trial that demonstrated improved pulmonary function in a surgical group, particularly in the pediatric population, although there were some socioeconomic distinctions in that outcome metric. There is one retrospective trial published in 2004 looking specifically at lung transplant patients who underwent endoscopic sinus surgery. And what they demonstrated was that in patients who had what they termed successful sinus surgery, there was less tracheobronchitis and less pneumonia than in the patients who had ESS failure, and less than in the patients who didn't even have cystic fibrosis. And this sort of starts to hint towards the power of endoscopic sinus surgery in the transplant group. In general, to kind of sum up the surgical literature that's out there, it seems that symptoms improve, but it's pretty difficult to demonstrate significant improvement in other outcome metrics. Lots of these trials demonstrate that PFTs simply don't improve from sinus surgery. Now, there was a study published a couple years ago out of Denmark that demonstrated that sinus surgery postpones gram-negative lung infections. And this was a cohort study looking at 106 patients, including transplant patients. And what they demonstrated, this was sort of the first paper that detailed a combined surgical and postoperative medical regimen, including colistin irrigations in the operating room and postoperatively, and serial cultures and serial examinations. And what they demonstrated was that treating these patients with a combination of medical and surgical management can significantly improve not only their sinus disease, but also their lung disease. And that kind of puts together some of the concepts we've been discussing. This patient always stands out to me. I managed this patient as a fellow. It's a 5-year-old who had cystic fibrosis, and he kind of captures lots of the stuff that we see in CF. We can see his maxillary sinus medial wall has bulged out all the way to his nasal septum, causing significant nasal obstruction. And this is a kid who had no lung disease. We can see when we look inside his nose, he's completely swollen shut, totally full of polyps, mucosal disease. And behind every piece of edematous mucosa, here's that bulging medial maxillary wall. Behind every little piece of edematous mucosa, we just see pocket of pus after pocket of pus, such that even out as a 5-year-old, his medial orbital wall had been eroded. Here you can see with pressure on the orbit, that dehiscent bony ledge. And the posterior table of this frontal sinus has also been eroded. And here, looking up into the frontal, after we've washed out all the pus, we can see that pulsatile posterior table. So these can be pretty aggressive infections, even in a 5-year-old, but by creating these wide open cavities, we can significantly facilitate topical medication delivery, and topical debridement access in the office. What about management of the frontal sinuses surgically? Well, here's a 19-year-old who has an unusual, atypical picture for cystic fibrosis because his frontal sinuses are diseased and his maxillary sinuses are pretty healthy. We don't often see that in patients with cystic fibrosis, but here I do what I kind of refer to as a mucosal preservation draft 3. Now, these patients get enough crusting from sinus surgery that if you're going to do extensive drilling, I think it's important to use mucosal flaps and grafts to minimize the amount of exposed bone after surgery. So here we can see with a 0-degree scope, we've got our superior septectomy, and using a kerosene ronger and a straight microdebrider, we can do this draft 3 all with a 0-degree scope and maximize our mucosal preservation. So here we can see our septectomy. Here with a 0-degree scope, I'm looking up at my frontal intersinus septum. And with a caudal elevator, I'm going to elevate the mucosa off of that intersinus septum, drill away that bone, and keep that mucosa so that I can lay things back down and try to create this cavity with as little exposed bone as possible. And we can see that a straight suction can get across my septectomy into that frontal sinus bilaterally so that I know I'm going to have easy access in the office postoperatively, and I'm going to have better access for topical medical therapy delivery. Here I can see I've kind of tried to keep my olfactory clefts open so that we can ideally preserve olfaction. And why is it so important to have 0-degree visualization? Well, it turns out 0-degree visualization does predict improved topical irrigation delivery. So where are we going with CF/CRS? Well, the last couple of years, we've seen a tremendous breakthrough in therapy for these patients in the form of CFTR modulators. In 2019, a triple therapy combination of CFTR modulator therapy was approved by the Food and Drug Administration in the United States. This includes elexacaftor, ivacaftor, and tezacaftor, all three of which act on the CFTR protein in a different way. And the combination of these three is extremely effective at maximizing the function of the CFTR protein, which specifically in patients who have at least one delta F508 mutation. And as I mentioned, the delta F508 mutation is extremely common among these patients. Now, it turns out that not only does the triple therapy of these three drugs significantly improve pulmonary disease and BMI and lots of other cystic fibrosis outcome measures, it's also great for sinus disease. And we demonstrated that across the SNOT-22 scale, there is a dramatic improvement in essentially every symptom subdomain for patients who are taking this triple therapy CFTR modulator. There have been a couple other publications that have demonstrated something very similar. So I think we really are on the cusp of an exciting transition in the way these patients are managed. And I'm very optimistic that over the next generation, cystic fibrosis will become an unrecognizable disease from what it was just a generation ago. So what else is in the future of how we understand and manage cystic fibrosis chronic sinusitis? Well, I think we need better ways to define and grade this disorder. As I mentioned, we don't have great objective metrics for understanding this disease because the symptomatology is so unique. Number two, I think drug delivery is huge for this disorder, as it is for many other forms of chronic sinusitis. The Alabama group has done an outstanding job of really pushing the envelope in terms of how we can deliver therapy topically in the sinuses, including even some of these CFTR modulators. That the CFTR modulators seem to have very effective topical action in addition to systemic action in at least a preclinical model. I don't believe it's been trialed in humans yet. Medical therapy to target these mutations directly, of course, have already been rolled out in the form of these CFTR modulators. Unfortunately, there are still some CF patients whose mutations are not compatible with the CFTR modulators that are on the market currently. There are more under investigation, and hopefully we can get to pretty much every mutation out there so that every CF patient eventually becomes a candidate for a CFTR modulator. Prophylactic sinus surgery for patients who don't have lung disease but do have sinus disease might have a role for some of these patients. And postoperative eradication therapy to get rid of some of these very aggressive and virulent organisms is going to be critical as well. We have seen enormous strides in research looking at these patients, and I'm excited about the future of CF/CRS because I think this is a great time to be taking care of these patients. In just the last few months, two very important publications have come out. One is the Management of Cystic Fibrosis Chronic Sinusitis, an evidence-based review with recommendations that reviews some of these concepts. And lastly, Doctors Adam Kimple and Brent Sr. worked closely with the Cystic Fibrosis Foundation to develop the first set of CF guidelines, which are published this year in the International Forum of Allergy and Rhinology. So in conclusion, CF/CRS is a complex and distinct disorder with tremendous potential for rhinologic interventions. A combination of surgical and medical management is key for these patients, and we should always be thinking about the multidisciplinary management for these patients who have lots of pulmonary and other systemic disorders as well. A few other citations for further reading. Last thing I would say is just that cystic fibrosis patients, I think, happen to be just an amazing group of patients. They are resilient and down to earth, and it is a privilege to take care of them. And I wish you all the best in managing your CF patients as well.